you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
You know, got his wrist pain by doing over-aggressive high fives to his buddies.
Hey everyone, Mike and Matt here with a special guest today, Jorge Otero, in a special episode.
That's right, we're calling this episode our Stories episode.
We occasionally get emails from the ultrasound heroes out there that are actually doing the random stuff we talk about and making a difference for real patients. So we thought we'd highlight a couple of those.
Jorge Otero is Emergency Ultrasound Director at Charlotte Hungerford Hospital. He's also the Development Chair of the Society of Academic Emergency Medicine, the Global Emergency Medicine Academy. He's a lecturer in the Division of Health Policy at Yale, and I think he's the new president of the Connecticut chapter of ACEP. I hope I've got all of that right.
So Jorge, let's get right to it. We've been emailing you because you've had a couple of awesome cases where you actually used the ultrasound-guided Crike technique that we talked about on the podcast about a year ago and was published a few months ago in AEM.
Now, the AEM article was a cadaver study, and we had the lead author on the paper, Keith Curtis, demonstrate the procedure on a cadaver. But you've actually done this on 2 patients now, 2 real-live people. Can you tell us about these cases?
Hey guys, first of all, I want to thank you, Matt and Mike.
Jorge, sorry for interrupting 3 seconds in, but if you're listening to this, Mike and I just want to tell you that we appreciate all the nice things you said about us. We cut it out because we're pretty sure no one else wants to hear that stuff except maybe our moms, but we'll forward the audio on to our mothers. It doesn't mean that we don't appreciate it though, so don't be offended we cut it out. Mike listened to it about 100 times, and I still cry a little bit every time I listen to it, which is down to 4 times a day now.
I'm a part of the Global Emergency Medicine Academy, and we're trying to spread, emergency care or how to provide quality emergency care around the world. So I strongly feel that point-of-care ultrasound is a safe and cost-effective technology to assess and diagnose time-sensitive emergency conditions that can be and it can really be a great tool in middle and low-income countries where we don't have all this other technological advances like MRI and CAT scan, plus it's safe. Okay, before talking about the case, I really would like to give special praises to Keith Curtis, the lead article that you referenced in the Journal of Academic Emergency Medicine, describing this very useful technique of ultrasounded guided bougie-assisted cricothyroidotomy. I've been following your podcast. I'm a big fan since it started, and view the episode when Keith describes this technique and how he used it to secure a difficult airway, especially in patients with large BMI. And through this, I applied it and I successfully utilized it in 2 live patients. Okay, so the first case was a 41-year-old male. He came to the emergency department. We have a single coverage community hospital, and I'm the ED guy. It was a very cold April morning, and it was about 4:50 in the morning when you think, things are kind of slowing down. The paramedics patched and this patient was a patient which used to come to the emergency department frequently with a long-standing psych history, and he was found by a neighbor, apparently, in the street in flames. This was gruesome. Apparently, he poured gasoline on himself and lit himself on fire. Not only me, but all the nurses were in a state of shock. It was really scary. The patient was about 6'6", and he weighed about 470 pounds. When he came in, no vital signs could be obtained, except we knew he was alive because he was flailing his arms and making these guttural sounds. I always keep the ultrasound machine in the trauma room, so I used it first to show that he had carotid blood flow and that his heart was beating, just to make sure that he was still alive. The face and the shoulders and up to his midches were totally charred, carbonized. I placed 2 IOs in both tibias and infused fluids. I gave him propofol, we sedated him, but he was very restricted, and basically he stopped breathing, and I hadn't paralyzed him or anything like that. The patient's face and neck, as I described, were so badly burned and charred that it was almost impossible to open his mouth at this time. Now that he was not breathing, I paralyzed him, but still it was almost impossible to open his mouth. I used a gyroscope and managed to go in and look into his oropharynx, which was also burned. There was soot all over the place. It was edematous and hemorrhagic, and I couldn't visualize anything. At this point, I needed to provide a surgical airway and use this ultrasound guidance technique, as described by Keith, to perform a crike and then visualize and secure an airway. What I did is I used the high-frequency linear transducer, have a sonar machine, and I oriented it longitudinally with a marker to the patient's head to identify the cricothyroid membrane. The patient already was sedated and paralyzed. I incised the skin with a scalpel and made a approximately 2 to 3 centimeters vertical incision along the axis of the probe. I did longitudinally along the axis and displaced the ultrasound probe laterally to visualize the airway. After that, what I did is I dissected the tissues with Kelly forceps and also my right index finger. I still had the ultrasound, and I'm using the ultrasound probe with my left hand and holding the scalpel and the forceps with my right hand. I had a nurse actually who was helping, and she sometimes helped me with the ultrasound probe. I was able to visualize the cricothyroid membrane, and then after that I could visualize the forceps. For the metal is a strong reflector in its shadow as I approach the cricothyroid membrane. After dissecting the tissues that are they were very friable, I then incised the airway with a scalpel. Some air bubbles came out, so I thought, yeah, I'm in the airway for sure. I could be in the esophagus too, but no, I was sure I was in the airway. Inserted the bougie, and as I inserting the bougie, I went through and I felt that hold up that Keith describes. I then proceeded to insert a 6 French pediatric ET tube over the bougie, but at this point I got stuck at the airway orifice. I looked with the probe. I knew I was the bougie's in, shadowing. I could see it going through the cricothyroid membrane, but I couldn't put it through. So what I did is I stuck the Kelly forceps around the bougie and widened the airway orifice without pulling the whole tube out, and then successfully inserted the ET tube that it passed smoothly, as Keith describes, through the cric membrane. After that, I confirmed the placement by visualizing the airway and the shadow artifact caused by the tube as it enters the cric membrane, as it enters the airway, and you guys could see it in the images. I looked in the actual and sagittal planes to visualize the airway, and I also obtained confirmatory ETCO2 capnography and also did a chest X-ray. It was, as you know, very difficult. It was impossible to obtain oxygen saturation and blood pressure using the ordinary method, so I had to use ultrasound again to show that there was perfusion. The patient survived, and he was transferred successfully to the specialized burn center in Connecticut. Unfortunately, this guy survived for 3 weeks, and eventually the family decided to withdraw life support measures.
Okay, so I know what you're thinking. Thanks to this ultrasound-guided cricothyrotomy, this family got a huge ICU bill, and that's about it. Well, fair enough, but it's still pretty nice to hear how this was used in a real patient. This guy definitely had more of a chance of surviving than the cadavers this was originally performed on, and the next person that this is done on may survive. So, there's my answer to your smart aleck thoughts in that smart aleck mind of yours. And don't call me paranoid for assuming you're thinking smart aleck thoughts. I can read your mind, and I don't appreciate what you're thinking right now either.
But again, it would have been extremely difficult to secure an airway on this patient if I didn't have ultrasound. There were no landmarks. He was a high BMI, and his neck was very, very large. I was able to visualize, and you could see the images, the thyroid cartilage, and as Keith described, it moves inferiorly, and then the cricothyroid cartilage as well. Both structures in this patient were about 3 centimeters deep, and in the anterior neck, as seen in the images. And between these two structures lies the cricothyroid membrane, which produces this slightly hyperechogenic signal, different from the adjacent structures. It was hard for us seeing this poor guy, but luckily we secured an airway and he left alive. The second case, and it's not that I'm looking for cases, but after that case, another case, a 56-year-old man who's been bedridden. He was about 500 pounds, bedridden for a long period of time, who had liver failure and came in anasarca and with a massive recurrent GI bleed due to esophageal varices. Again, this case, the airway was extremely edematous. The uvula was huge, the tongue was huge. It was impossible to visualize this guy's airway. And after probably 4 unsuccessful attempts using the glidoscope, a MAC blade, I had to recur again to the ultrasound-guided bougie-assisted cricothyroidotomy. The tissues in those patients were also very friable as the previous case, but there was not as much bleeding and probably was due to profound anemia. But you could see that that subcutaneous fat in the anterior neck was basically weeping. It was edematous, and every time I incised it, it was just fluid and plasma coming out. Again, I utilized the high-frequency linear probe to visualize the cricothyroid membrane and made the same it made actually a wider incision with a scalpel above the cric membrane. I made about a 4-centimeter incision this time, which permitted me not only to dissect the tissues better, but also to visualize the scalpel and the bougie as it slid above and through the airway. I successfully secured the airway, and unfortunately, this patient only survived 3 more hours and expired because of continuous blood loss. But the airway was secure, and we could ventilate this patient successfully. But we're inserting something in a deep tubular structure that we could not see otherwise, and in this case was the airway. And I feel that the ultrasound-guided budio-assisted cricothyrotomy is a great technique. Again, one of the things I want to comment is the difference in the length of time that I experienced in contrast to Keith's experience with cadavers. And I think it's due to the fact that live patients have less rigid tissues, and the tissues are more friable and they slide. And of course, there's very significant bleeding, especially from that subcutaneous fatty tissue in the neck that is anterior to the airway. It took me approximately an average about 80 to 90 seconds to complete the whole procedure in both patients, according to the nursing notes. I did identify the cricothyroid membrane in about 3 seconds, and it was similar to what Keith describes in his cadaveric models. As a matter of fact, I encourage you guys who do ultrasound, try to look at live patients and look at the airway and look at the cricothyroid membrane in patients with high BMI, and you could see it. I did spend most of my time, I think, dissecting the tissues, and it was due to tissue friability and significant bleeding. I also spent more time than expecting because I had to pull back on that ET tube and had to wind the cric orifice in the first case. I think I could have prevented that if I would have been a little more generous in making a wider incision with a scalpel when I was going through the cric membrane. So I think you guys are really making doctors great. So guys, keep that podcast going, and hope to hear from more novel techniques using ultrasound soon. Okay, take care. Bye.
Thanks, Jorge. That was great. It's really inspiring to hear these cases of actual patients getting airways via this ultrasound technique. Hopefully hearing your story will give someone else in a desperate situation the courage to try this when nothing else is working. So now it's time for a couple stories from Dr. Mallon, and you guessed it, they involve the heart. This is a continuation of some cardiac cases from a while back, so ignore the case numbers when you hear them.
All right, welcome back to our cardiac case series. We're going to start off with case number 3 here. And before we start off, we're going to have a little name that stash. So, Matt, any chance you could name that stash?
Salvador Dali.
Genius. Smart guy. Really he's a smart guy. So this is Salvador Dali, and he's a pretty famous artist. If you haven't checked out his stuff, it's pretty good stuff. Case 3. Case 3 is the case of a 33-year-old semi-pro Nordic skier who presents with syncope. He was basically out doing some hills today and had sudden onset of shortness of breath, palpitations, and passing out. In review of systems, he does inform you that his last VO2 max was calculated at 72 based on underwater testing, and otherwise he has no real past medical history, family history of sudden cardiac death, or none of that.
This is in Kentucky, right?
Right, yeah, actually lives in Lexington, I think.
Okay. Yeah.
Near some place called Versailles. So, physical exam is notable for a heart rate of 43, a respiratory rate of 12, blood pressure of 115/62, SATs of 102%. He's actually a little bit disappointed that his heart rate is now in the 40s. Normally it's in the 30s. So his physical exam is otherwise normal. You get an EKG because, hey, that's what you do when people act like this. And you see this sort of EKG, and we'll leave this for Amal again, but I think you can notice that it's maybe just a little bit abnormal. There's some weird stuff going on in lead 3, and otherwise I don't see much too concerning. So what are we going to do next? Clearly, we're going to get a trope. Happens to be negative in him. You get a CBC, which is normal with the exception of a crit that's 53, and his BNP is otherwise normal. So what next? Obviously, we're going to ultrasound him. So you put the ultrasound on the patient's chest, and you first go for a parasternal short axis view, and this is what you see, Matt.
Looks like there's an anomaly there.
Yeah, there's something weird going on for sure. So what are you looking at? Any idea here? What is this massive largeness?
Well, it's kind of shaped like, I'll describe it as an Epstein appearance. Yeah, I think that's probably the best way to describe it.
So what you're telling me is that this is the left ventricle, this little tiny thing down at the bottom?
Mm-hmm.
Okay. So if this is the left ventricle, then I guess that makes this the right ventricle? and that's right atrium. So we're looking at a short axis, and normally the right ventricle is this little tiny thing that just sort of sits on top of the left ventricle as like sort of a concentric structure. But interestingly, this one's huge and dilated. Let's look at some more images of this. So this is an apical 4-chamber view, and now we're noticing that the right ventricle is freaking ginormous. So it's sort of huge here and takes up the majority of the screen, while the left ventricle is pretty small and I guess otherwise fairly normal looking. The right atrium is also pretty big and dilated. There's also this really weird thing where the mitral or the tricuspid valve is actually sort of like pushed down a little bit on the septum. It looks like it's almost into the ventricle a little bit.
So it's higher on the picture, but down because the probe is looking from inferior, correct?
Towards the apex.
Right. Okay.
So Matt hit on this already. This is actually Ebstein's anomaly. Ebstein's anomaly is a congenital heart disease, and it comes from apical displacement of the tricuspid valve. So that means the tricuspid valve inserts to the septum closer towards the apex of the heart, and that causes this thing called atrialization of the ventricular wall, and often is associated with an ASD or PFO. And about 50% of these people actually have Wolff-Parkinson-White. So it's one of the most it is the most common cardiac anomaly associated with Wolff-Parkinson-White, which is, I think, probably what this patient had given their history of syncope. So the treatment is associated with surgical resection of the atrialized right ventricle, and they actually sort of move the valve, and then they often ablate the Wolff-Parkinson-White tract. Usually do a maze procedure for refractory AFib and other complication associated with this sort of disease.
Did you say you usually do a maze procedure?
I usually do. I maze them up.
Okay.
They get mazed when they're in the emergency department. So that's sort of an interesting case, and a nice little concept is, if somebody has syncope, you should probably do an ultrasound of their heart because you never know what you might find. So case 4 is a 42-year-old male with nausea and vomiting and syncope. He describes 2 days of diarrhea and vomiting after eating at the UK cafeteria. Hasn't been able to keep any fluids down over the last 24 hours, and every time he stands up, he faints. He's fainted probably more than 10 times.
What is that food?
It looks like chicken salad.
Oh,
Make you want some chicken
so
salad?
delicious.
Oh, Jesus. So physical exam is, in general, he's awake, alert. Otherwise, pretty much normal. His cardiovascular exam, he's maybe a little bit tachycardic, but otherwise not too remarkable. And neurologically, he's non-focal. So what next? So he's been fainting a lot. So you know what I do when people faint? I often put a probe on their heart and take a look. Here's an example of an apical 4-chamber view on this particular patient. And do you see anything exciting here, Matt?
I mean, the left ventricular walls look like they're touching, so cardiac output of like 100% or something, it looks like.
Yeah, so maybe hyperdynamic. Nice pickup. I
am kind of surprised at the heart rate there for this person who I'm assuming is probably dehydrated.
Okay. All right. So in this particular example, the heart rate's not as fast as you would expect, but nice pickup on the ventricular walls touching. I like that. Here's another little picture. Put some color flow on the mitral valve there. Do you see anything unusual?
So blue away, red towards. Maybe there's a little bit of mitral valve regurgitation with that blue.
Yeah. So you can't really use that blue away, red towards thing when you're looking at regurgitant lesions because the velocities are going so fast that they do what's called aliasing, where it just gets really bright and then it changes colors and it goes back and forth. If you look at that jet, you can see it's sort of like a rainbow. It goes like blue, red, blue, red, blue, red.
Well, okay, yeah.
So that's because the colors change because it's going so much faster than the blue or the red colors on that graph on the right-hand side of the screen. So, but you're right. There is definitely mitral regurg on this jet, on this particular image. Here's a parasternal long axis, and you want to comment on this at all, Matt?
Looks hypertrophic now. I mean, those walls are really thick in that left ventricle.
Good pickup. These walls are ginormous. So the interventricular septum here is 2.33 centimeters. The posterior wall is 1.46 centimeters. So that's sort of unusual. You're basically telling me that the septum is almost twice the thickness as the posterior wall. So the diagnosis in this case is hypertrophic cardiomyopathy. So this is a genetic abnormality of the cardiac myocardium. Occurs in about a 0.5% of the population, causes a thickened septum, and typically it's asymmetric, although there are many cases of patients with symmetric hypertrophic cardiomyopathy, although we typically talk about the septal only kind. And what it causes is it causes a dynamic outflow obstruction, and that dynamic outflow obstruction makes you syncopize, usually. So as the patient's preload decreases, their heart doesn't fill as much, and when it doesn't fill as much, their obstruction gets worse, and they basically significantly decrease their cardiac output. So it's sort of like they're riding on this, they're teeter-tottering on this edge until their preload drops off a certain point, and then at that point they're pretty much screwed, and they can't increase their cardiac output at all. In fact, it decreases.
So that was a nice case. I mean, you kind of threw me off with the whole history because I thought this was just going to be syncope from severe dehydration.
I trick you.
You did. You got me. Great job.
Let's talk a little bit about it, because I want to talk about the physics of this stuff because it's pretty interesting.
Mike, before you talk about the physics, which really we're all so excited to hear about, I do want to confirm what some of you may be wondering right now. Yes, we're talking about the disease, hypertrophic cardiomyopathy, that you occasionally hear about actually killing a young, otherwise healthy athlete. It's a really tragic thing, and there's been some talk of screening athletes, maybe at the collegiate level, for this disease. All of these athletes pictured here died of this, and those deaths may have been prevented if this had been detected early. It's a very interesting discussion when you start looking at the possible benefits versus costs of screening, and we're not going to get into that today, but I just wanted to make sure we're all clear on what we're actually talking about.
So a dynamic outflow obstruction occurs by having the mitral valve push up against the septum sort of during systole. So instead of the mitral valve staying closed during systole, because that little orifice is so small, it creates a negative pressure, and that's called the Venturi effect, where basically as flow has to converge through a smaller orifice, it decreases the pressure when it's going through that orifice, and that negative pressure, or that smaller pressure, basically pulls the mitral valve anterior leaflet up against the septum. So the leaflet itself acts as the dynamic outflow obstruction to the left ventricular outflow tract, and instead what you get is you usually get some mitral regurg instead. So all of the flow is going out the left ventricular outflow tract. Because that orifice is so small, the mitral valve pushes up towards the left ventricular outflow tract, and you get regurgitation instead. Here's an example of how that happens. So here we've got flow going up through the left ventricular outflow tract. You see in a patient with a thicker septum, you basically get that negative pressure. It pulls the mitral valve towards the septum, and you get regurgitation instead. Here we're looking at just sort of a close-up view of the dynamic outflow obstruction. You can see how in systole you get sort of movement of the mitral valve. It's mostly in systole. You get movement of the mitral valve up to the septum. One way to identify that is actually putting continuous wave Doppler through the left ventricular outflow tract, and you get this classic dagger-shaped appearance. Normally, we get a very nice smoothed off curve here as the outflow or in the outflow tract, but instead you get a sharp dagger-shaped appearance of the continuous wave, and that's because of the increased velocities in systole as the mitral valve is coming up and pushing up towards the septum. You get a smaller orifice and therefore higher velocities towards the end of systole, not equal velocities through the entire part of systole like in a normal heart. One of the ways we check for it is by putting M mode on the mitral valve. So just as if you were measuring somebody's EPSS, you would put the M mode right through the mitral valve, and what you end up getting is a systolic hump, basically. So let's talk about that. So here we're looking at the mitral valve, and we're seeing the E wave and the A wave, but the unusual part is there's this hump portion after the E and the A wave. A normal one here in the top right part of the screen, you see that the mitral valve stays down during systole, but in the dynamic outflow obstruction, you have a large hump that pushes the mitral valve back up to the septum during systole.
Or pulls it back up.
Thanks, Matt. So there's some other causes of hypertrophic cardiomyopathy. There's definitely just the septal cause, which is the one I think we're most used to, but there's also sort of mid-cavitary lesions. So somebody with an aneurysm in the bottom right, for example, can get a mid-cavitary lesion. This is actually somewhat common in our elderly patients, where you actually see, instead of the mitral valve acting as the dynamic outflow obstruction, the center of the cavity, for one reason or another, secondary to hypertension usually, that causes the obstruction. Or you can get it apically. You can also get it with sort of, instead of asymmetric, symmetric hypertension and symmetric hypertrophic cardiomyopathy. So there's lots of different reasons for hypertrophic cardiomyopathy. The one we talk about most is obviously the congenital kind.
Okay, so that's it. We're going to leave you with this Name That Stash cliffhanger. Now, we've been having a lot of fun recently on Twitter, interacting with different people, having some pretty cool conversations. And if you want to be a part of that, follow us at Ultrasound Pod. And the first 3 people to tweet this episode using the Twitter button on the podcast side with the correct answer as to who owns this stash, we're going to give away a free Introduction to Bedside Ultrasound iBook. Be sure and tag us at Ultrasound Pod when you do it, and follow us if you're not. And if you want to practice doing ultrasound-guided crikes on a cadaver and learn this cool cardiac stuff with Blivus, Weingart, Noble, Mallon, Cliff Reed, Mike Stone, and more, go to CastleFest2013.com and register. Hope to see you there, and we'll be watching for your tweets. You're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.